Good still morning. I'm Don Lukoski on behalf of Mel. Want to welcome everyone who is here as well as everyone who's attending virtually to our abstract, one of our abstract sessions. Just a couple of announcements. We've had two community service events. One was our blood drive. We exceeded our goals. We saved over 100 lives in our host city of New Orleans. So I want to thank everyone for that. We also have another really important community event to let children who are undergoing cardiac surgery to hear a little bit of love from all of us. And there are cards still out there in the main hallway. So if you have time and an inclination, those will be actually hand delivered to the Children's Hospital here in town. There also is an event, a social event this evening at Sazerac. You can get your registration, your ticket over at the registration desk. And in between our sessions, you'll actually have a QR code if you also wanted to do it that way. The last thing is we have a really important event after this to honor a legend in our community, Bob Groom. And there will be lunch boxes outside. And we just ask that be a little bit fleet of foot so that we can start imminently and make sure we have adequate time to honor Bob and honor our community as well. So without further ado, I'm going to hand it over to Mel, who will introduce our speakers. We're going to have the presentations and then a short Q&A afterwards for each one. And we'd ask that you just announce who you are and go to the microphone so that those who are present can be heard in our virtual audience. And I'll also be monitoring the Q&A. So Mel.
Thanks, Donnie. So first we have Dr. Nousjka Vranken from Maastricht University Medical Center, and she'll be presenting on extracorporeal cardiopulmonary resuscitation. Time is tissue.
All right, good morning, everyone. Thank you for the kind introduction. Again, my name is Nousjka Vranken. I'm a cardiology resident and researcher in the Maastricht University Medical Center in the Netherlands. And I would like to talk about extracorporeal cardiopulmonary resuscitation, or ECPR. And I would want to highlight some of the pathophysiological processes and, on the other hand, some more practical aspects. I have nothing to disclose. So more than 430,000 deaths are the direct result of cardiac arrest each year in the United States alone. People suffering from cardiac arrest require immediate initiation of cardiopulmonary resuscitation, or conventional CPR, in order to allow a chance of survival. Even when doing so, outcomes are still very poor. So the basis of cardiopulmonary resuscitation is actually to create variations in intrathoracic pressure by compression and decompression of the thorax, together with ventilation. And if performed correctly, this results in approximately 30% of normal cardiac output, and optimistically also around 30% of cerebral and coronary flow. So as I highlighted before, outcomes remain poor. Approximately, wait, can I see the slides up close? Thank you. Approximately 10 to 15% in case of out-of-hospital cardiac arrest, and 30 to 40% in case of in-hospital cardiac arrest. And even these people who do survive, most of them suffer from severe neurologic or cognitive impairment, having a huge impact on quality of life. So ECPR is extracorporeal cardiopulmonary resuscitation, or is extracorporeal life support applied in the emergency setting of refractory cardiac arrest. So refractory cardiac arrest meaning more than 10 minutes of conventional CPR or more than 3 defibrillation attempts. So ECPR has been gaining more and more interest in research. However, several observational studies have been conducted, but merely 3 prospective trials, randomized trials, have been conducted, which you see here. So that is the Prague out-of-hospital cardiac arrest from 2022, the ARREST trial from 2020, the slightly more recent INCEPTION trial from 2023. The first 2 are both single-center studies, and the last one, the INCEPTION trial, entailed 10 Dutch hospitals. So when looking at outcomes in ECPR, that's obviously one of the main parameters that we are interested in. Here you can see a brief overview of outcomes of neurologic intact survival of patients receiving either ECPR or conventional CPR. And as you can see, both the ARREST and the Prague trial are in favor of ECPR. On the other hand, the Inception trial did not find any statistically significant difference between the ECPR and the CPR group. Though when looking at outcomes, I think it's very important to note the big differences in study protocol, in study methodology between the trials. And actually the ARREST and the Inception trial also included patients with a presumed non-cardiac origin of the cardiac arrest, while the Prague trial, on the other hand, also included patients with a initial non-shockable rhythm. So that does mean that there's quite a big heterogeneity of patients selected just in one study. So when looking at outcomes, I think it's very important to just take a few steps back first and focus on the underlying pathophysiology, since one has to try to grasp the complex pathophysiology before we can really focus on outcomes. So as soon as a patient suffers from cardiac arrest, what happens is that there's a switch from aerobic to anaerobic metabolism. ATP production ceases immediately, and the sodium-potassium ADPase pump fails, which results in ionic disturbances. So most prominently, influx of sodium and calcium and efflux of potassium. And all of these lead to various downstream mechanisms when the cells fail to maintain ionic balance. So very specifically, increased cytosolic calcium is responsible for mitochondrial dysfunction, induction of apoptosis, and also cell death. So the endothelial cells specifically, on the other hand, they're primed for what we call reperfusion injury or ischemia reperfusion injury. When they are primed doing hypoxia, when they're primed with a very specific pro-inflammatory markers. So that is basically what we also call in the literature the oxygen paradox. That means that tissues who are previously subjected to hypoxic injury, the same process basically continues. So that means aggravation of cerebral edema, aggravation of neuronal cell death, and even a lower chance of neurologic intact survival for the patient. So there's some leverage points when we want to really focus on how to improve these outcomes for patients. There are a few leverage points that might have been already proposed and described. So the first is hypothermia. So induced hypothermia refers to a body core temperature of below 35 degrees C, usually for more than 24 hours. And several studies actually already proved the beneficial effects. And it's based on the fact that hypothermia in a controlled manner decreases cerebral and systemic metabolic needs and thereby metabolic distress. Secondly, elevated head position, which is actually only studied up till now in conventional CPR in pig models, though it's based on an elevated head position, which means more venous drainage of blood from the brain back to the heart, a greater filling of the heart thereby, decrease of intracranial pressure, and thereby less impedance of forward brain flow. So these are some more or less practical leverage points which we should or could take into account. Maybe more important, maybe most important actually, is the precarious balance between oxygen delivery and oxygen consumption. So as you can see here, lactate, as you all know, is a known marker for accumulated oxygen depth. And here in this little graph, it's from a trial that is actually not published yet, but it's on patients receiving ECMO for refractory cardiogenic shock. And as you can see, lactate levels prior to support, but even after 26 hours of report, they remain significantly higher throughout time. So what that does mean, it merely underlines the importance of really focusing on efficient oxygen depth repayment. That might be easier said than done. So some of the points we could focus on is appropriate cannula selection and tailoring oxygen delivery, while also preventing hyperoxia, since that does produce a high load of reactive oxygen species with, again, a high load of ischemia-reperfusion injury. Some more theoretical leverage points are actually based on the same pathophysiological mechanisms that we just discussed. So, for example, depletion of calcium and also depletion of immune cell activity and specific harmful forms of nitric oxide are potential leverage points to look further into for future research. Also, administration of antioxidants, anti-inflammatory agents like corticosteroids, and anti-edema agents as mannitol, they're already in use, though not yet really studied or applied in the setting of ECPR. So all of these leverage points are not useful or are basically obsolete if we do not take the most important factor into account, which is time. So if the time, the low flow time, that is the time between conventional CPR and full support, or the no flow time, so the time between circulatory collapse and CPR is too long, that basically means that the patient has no chance really any of survival anymore. So this graph is from a Korean observational study, more than 8,000 patients, and in red and in blue you can see there the witnessed shockable rhythm and the unwitnessed shockable rhythm. And in the steep line you can clearly see already in the very first few minutes time really is tissue, and if we wait too long, if support is not properly initiated, the patient really has no chance of survival. So the first three studies that I highlighted on ECPR, obviously they also looked into this important factor. And here you can see an overview of the time delay between the 911 call and initiation of ECPR support. So on average, in the ARREST and the PROG out-of-hospital cardiac arrest trial, this time frame is, well, let's say more or less than 60 minutes. While on the other hand, the INCEPTION trial, this is closer to 75 minutes. And if we are really critically looking at these results, we could hypothesize that this 75 minutes may have been too long for the patient. So when we want to really look further into the logistics, like how can we optimize this, I want to highlight an example from the Netherlands. We have a regional ambulance service system in which the patient is on average reached in 9.5 minutes, and 95% of ambulances reach the patients in 17 minutes. So this may sound very optimal, though we still have to keep in mind that all of the next steps, like selecting the appropriate patient for ECPR, initiation of support, transport to the hospital, all of these steps do and will continue to take a lot of time. So in summary, when looking at patients suffering from cardiac arrest, as of today, outcomes are poor, and ECPR may be a good leverage point to increase chances of neurologic intact survival. Studies that we have up till now, they are really not yet there of giving the final clue if the efficacy is there, yes or no. And probably it's better to improve everything by 1% rather than improve just something by 100%. Thank you.
Thank you so much. That was a great presentation. We're going to take 5 minutes for a Q&A on this presentation before moving on to the next. Do we have any questions from the audience?
We don't recognize you in the back, so if you wouldn't mind just saying your name.
Bob Groom.
Thank you.
Bomet, Kenya. Dr. Vranken, welcome back to AMSEC. It's good to see you here again.
Thank you.
You've been here before. Anyway, thank you for sharing this ECPR concepts. One of the challenges that I've seen in the very few cases of ECPR I've been involved with is cannulation of a patient when a team is doing compressions. And I'm wondering, from your survey of the literature, do you know of any best practices? Usually these are done in the field. There's no fluoro. There might be echo, but can you just comment on that? best practices for cannulation, or do you think that's the real limitation, or is it getting the team there?
Oh, thank you. Thank you for the comments. I appreciate. I think the biggest bottleneck, the biggest challenge here is maybe not particularly cannulation, though it is a very important part of it. And as you described, like in the field, in the case of the out-of-hospital cardiac arrest, what we've seen from also the European studies, it looks very interesting, like out on the field cannulating while other people from the medical team are doing chest compressions indeed. That is very specifically for those few, like that handful of out-of-cardiac arrest patients. I think we can gain more knowledge, and there's more to improve if we focus on the in-hospital cardiac arrest patients, because of several points actually. Then the team is already there. That is a very important challenge in the out-of-hospital cardiac arrest patients indeed. So for the in-hospital cardiac arrest patients, you have the team close by. But what I think also is really important, you have more knowledge already on that type of patients, since patient profile really determines chances of outcome. So in these ECPR studies also, what they did not look into is the technical aspects of cannulation. No, they did not really describe much. And secondly, really the patient profile, because I find it kind of odd that in these studies we do compare, for example, the young female with massive pulmonary embolism found out in the field. We compare that to an 85-year-old male with known ischemic heart failure for 10 years. So I think based on those things, there's probably more to gain.
You have one question, just for maybe just a response in 2 minutes. What is your opinion on systems like Carl that do a controlled reperfusion with dedicated medications?
Yes, thank you. Very interesting question. I'm happy to have that question. So indeed, the Carl system is a system from our colleagues in Freiburg in Germany. And what they did is that they designed a very specific system with 2 pumps, and they are focusing on a huge list of parameters, so like the potassium, the calcium, the antioxidants. It's a very thorough way of monitoring and also in an attempt to correct. Though if you really look deeper into literature, all of these specific segments, there's not much evidence yet. Right. But I do really think this is a good approach, yes.
So areas for future investigation.
Yes.
Right? Thank you so much.
Thank you.
Okay, next we have Dr. Samuel Max from Erasmus University Medical Center in the Netherlands, and he'll be presenting on enhancing perfusion training through virtual reality simulation, a series of randomized controlled trials.
Thank you so much for the introduction. Very good morning to you all. My name's Samuel Max, and as said, I'm a resident and a PhD candidate in Rotterdam in the Netherlands. And on behalf of our team, I'm very excited to tell you this morning about how we're enhancing perfusion training using virtual reality and how we're validating that platform using randomized controlled trials. So just to start with my disclosures, I'm supported by a couple of grants and I work on the development of this platform. So I'd like to start with a video, and this is a ICU nurse who has no experience of working with ECMO or ECMO patients, and here she is performing a flawless circuit check on a test circuit. And the reason that she's able to do that is because she's just done the virtual reality training. So we built a virtual reality simulation platform for perfusion, consisting of 2 different simulators. The left simulator, the ECC simulator, is our cardiopulmonary bypass simulator, which includes modules like in the introduction module, preparing the heart-lung machine, going on bypass, troubleshooting during the bypass phase, and weaning. And we performed a randomized control trial on that, which I'll tell you about in just a moment. And on the right side, we have the ECMO simulator, which similarly features modules like the introduction, the initiation of ECMO, the management and the disaster management, as well as weaning from ECMO. So what we did is we performed randomized controlled trials on 2 of these simulators in order to show their educational validity. Why did we choose virtual reality as a modality? Well, we think it's because it provides an immersive learning environment. It means that we can train critical skills in a safe environment, in a sandbox. We can make mistakes, we can learn from that, we can see the consequences of what we do if we're not doing things properly. And we're able to practice repeatedly over a course of time, whenever it suits us. We're also independent of a trainer, a location, as well as any simulation, physical simulation equipment that's required. And we can do that alone, or we can do that together with colleagues at a distance. So a little bit about our development strategy. We use this 1, 2, 3, create, test, validate system. So what that means is we start with development, we have a huge amount of experts and stakeholders who test the simulations for us, then we go back to the drawing board again, we work with development until we're ready to validate the simulations, at which point we perform the studies and then learn from them and then go back into the development stage to make sure that the learning efficacy of the platform is as high as possible. So first to talk about the cardiopulmonary bypass simulator. We performed a feasibility study on this and was published last year, in which the vast majority of perfusionists found that it was a very useful training modality. So for us, the logical next step was like, okay, it's useful, but how does it compare to what we're doing at the moment? So we wanted to compare that in terms of the learning performance, and we wanted to also do that in terms of our students' experience with the simulation. So the usefulness, the satisfaction, the ease of use, and the immersiveness. So what we did was we performed a randomized control trial with 41 allied medical providers. They're medically trained, but they have no prior knowledge or experience with perfusion. And we randomized them into 2 groups. The intervention group received virtual reality training twice, and the conventional group received conventional classroom training in the form of a video produced by our head perfusionist in our center. And then what we did was we brought them back together again, and we asked them to fill out a questionnaire on their experiences of their training, and we asked them to do a written knowledge test to see how much they'd learned throughout their respective trainings. So let's take a look at the written knowledge test scores. So what we see immediately is that the virtual reality group scored better than the control group, and because we let them do it twice, they even scored significantly better the second time. And that really highlights the flexibility of virtual reality in performing repeated training over the course of time. Looking at the subjective markers as well, we found that the virtual reality group found their training to be much more useful than the conventional group, and they also remembered their steps in preparing the heart-lung machine better than the conventional group. They also felt more actively involved in preparing the heart-lung machine. So then to move on to the second randomized control trial that we're going to tell you about this morning, that's on the ECMO simulation. And our ECMO simulation has a bunch of modules, but the one that we used for the trial is our circuit check. So that's for people who are working with ECMO, including ICU nurses, and pretty much anyone who comes into contact with those patients. So what we did was we took our cardiothoracic surgery nurses and ICU nurses, again, who had no experience of ECMO or ECMO patients beforehand, and we randomized them into 2 groups. Again, with the first group receiving conventional classroom training and the second receiving virtual reality simulation only once this time. Then we asked them to do a practical circuit check test, which was like the video that you saw at the start of the presentation, and we scored them on how many mistakes they made. So these are preliminary results. This trial is still in progress. You can see one of our participants on the left-hand side here was kind enough to provide permission for us to use his image. But what we see here is that the VR group is making around half of the mistakes that the conventional group is making, and that's already significant at this early stage. And a couple of highlights from the subjective measures. 100% of the participants agreed that they learned a lot from the ECMO simulation in VR, and 100% were satisfied with the quality of the simulation. So to talk a little bit about how we're implementing the platform in Europe, where at the moment we work with the Dutch National Perfusion Society, and you can see some images here from our young perfusionists in their first and second years of training, where they are receiving VR training once or twice a year, and we're looking for other international partnerships which are being rolled out this year. And what we want to do is we want to integrate VR training into the educational curricula, both in Europe, but also hopefully in the United States. And we'd like to offer academically certified training. And to take things one step further, in order to make our simulations as realistic as possible, what we're doing is we're taking real data from the heart-lung machine and from the ECMO, and we're combining it with the clinical data recorded in our electronic patient record. So think about pressures, lab results, all that sort of thing. And we've combined that and linked it into a database. And then in the database, we let loose a deep learning model, and the idea is to build a very accurate simulation, an AI simulation of that patient. And then we can take that model and put it back into the virtual reality simulator. And the idea is then that when we're interacting with the patient in VR, if we're turning the flow up, for example, all of our pressures are going to respond. If we put a clamp somewhere, everything, even the lab results, are going to respond as they would in real life. So just to conclude quickly, we built a VR platform for perfusionists. We did 2 randomized control trials in which the VR group outperformed the conventional group, and we're working now to expand the scenarios and the center-specific flexibility of the platform. So I'd like to thank my team. Thank you for listening, and we're always looking for more international stakeholders. If you're interested in hearing more about the platform, please scan the QR code that's on the screen. And thank you for your attention.
Thank you so much. As Luke is going up to the microphone, I don't see any questions yet in the chat, but I wonder if you wouldn't mind speaking to 2 things about your methodological approach. Mm-hmm. One is whether or not the assessments were validated previously, and including retest reliability. Mm-hmm. And then the second is, with the virtual simulator, how does it account for people who have visual defects or deficiencies, including, not limited to, color blindness? Mm-hmm.
Those are very good questions. So in terms of the test, it was produced by a Delphi process of perfusionists who contributed questions, and then we split them over 2 tests. We didn't perform any IRR analysis, but we figured that with the expert input that we had from perfusionists across different centers, that would be the best test that we could provide for the groups. And speaking to the issue of visual defects and things, at the moment we've had around 700 people through the simulation at this point, of which I think we had around 2-3 people maybe that felt a little bit of dizziness or were not completely comfortable in it. I have a very good friend of mine who is colorblind, and I asked him to do the simulation because I had a very similar thought that this might not work. But because it's so realistic and so immersive, it looks like real life does to him. So the colors that he sees in real life are reflected in the simulation. Obviously, he's not seeing the same spectrum that you or I might see, but there was no issue really with him going through the simulation.
Thank you. Thank you. Looks like we have 2 questions. Luke.
Luke Bus from Iowa City. Congratulations on your research. Looks really nice. I just have a remark about your 2 groups. If you would put a classroom group of students, comparing them with an actual heart-lung machine and a simulator, I think you would come to the same result. So I think your comparison is a little bit unfair, but just a remark, you should compare other things, like you don't need 20 heart-lung machines, you can train 20. And then another question is, how will you validate this in clinical practice? How will you see if this is actually the same outcome when you put perfusionists out in the clinical arena?
I really appreciate those the remark and the comment. I think in terms of the comparison, at least what we're doing in terms of training our perfusionists, we don't start them immediately in the OR. They go through classroom training first. So this actually does reflect real-world practice. And ideally, of course, our comparator groups would be people who are going into the OR, seeing how the heart-lung machine is prepared, and then we compare that in virtual reality. But unfortunately, to do that with 50 people is tricky at the moment. We haven't received permission for that, which is why we did the next best thing in terms of the classroom training. But I really do appreciate that. Would you mind repeating your second question?
The validation in the clinical arena.
Yeah, I think that's a really good point. So for the modules that we validated now, the actual clinical efficacy of that is difficult to test. However, with the disaster scenarios that we're doing now, our plan is to perform a similar randomized control trial, but then physically assess them on a heart-lung machine with a Khalifa simulator. That's about as close to actual practice as we can get in order to validate that. And then if you're into looking at patient outcomes, you're going to have to perform a bigger study over a longer course of time in order to compare, let's say, the outcomes of centers that do VR simulation and centers that don't. But that's something that we're looking for the next 3 or 4 years. Thank you.
Dave, could we take one question from the audience?
If you have to, yeah.
So there's a question from the online audience asking if there is a plan to bring this to other countries in the future?
Absolutely, absolutely. And our philosophy is to build this as generically as possible. We've chosen the heart-lung machine that is most commonly used around the world in order to ensure that it is applicable to all the different centers. But what we're working on really hard right now, and why we need more input, is to make the center-specific idiosyncrasies, make them applicable across lots of different places. So yeah, absolutely, that's the plan.
Dave.
Samuel, this is great work. Thank you so much for leading efforts on this. This is really exciting and innovative for perfusion education. I know you were short on time up at the podium, but two really quick questions. In your development of the software, did you validate the physiologic response of the software and that it actually behaves or responds like we would expect a patient? And then the second question is, I know you had indicated in your first randomized controlled trial bringing people in that didn't have ECC experience, but was there a consideration of doing a pre-post, assessing their knowledge base before the intervention, and then again to see what the net effect is rather than just looking at the post scores? Thank you.
Thank you for those questions. So addressing the physiology question, at the moment there is a physiological model which is based on data that we've pulled out of the heart-lung machine. However, that's a placeholder for our later AI model, which is going to go in and be much more comprehensive, let's say, in the different actions that you could theoretically perform on a heart-lung machine in order to see what the physiological response is. So that's something that we're working on right now, and we hope to be presenting on in October. And forgive me, your second question.
The pre-post, the
Yes.
change in knowledge.
Yeah, we didn't do that, and that's a reasonable consideration to maybe have done that. However, we were confident that the students had absolutely no perfusion knowledge to start with, and therefore their test performance would have been essentially around that of random guessing.
Great, thank you. Congratulations again.
And it looks like we have one question, just a brief question and a brief response.
Gotcha. Rob Johnson, Director of Simulation for Orem. I appreciate your work. I appreciate you sharing with us. I'm also involved in the VR space and trying to create for students in perfusion. And my big question is not only with the way that you're using a deep learning model to actually help propagate the data that you actually have from, I'm not sure your data pool, but do you de-identify that data and do a trending value away from the real numbers, or how does that work there in Europe? And then the second question, if that's okay, do you want to take it into mixed reality?
Great questions. Regarding the trending, I want to give a short answer on AI because I could talk about it for a long time, but basically the short answer is yes. You start with a set of initial conditions for a case, and then based on your inputs on that, you're going to deviate away from the start conditions. Yeah, absolutely.
Gotcha. And then mixed reality, you said?
Yeah. So mixed reality, it's an interesting one because there's a lot of power in mixed reality in terms of what we can do. But I think then you enter a realm where you need a physical heart-lung machine to practice on. And actually then at that point, it's probably better just to go fully physical and use, for example, the Khalifa simulator, which is fantastic. And really what we're trying to do is not replace physical simulation, but provide a VR simulation platform as an adjunct. Probably haven't got mixed plans for now.
Thank you.
Thanks again.
Congratulations. Thank you so much.
Thank you so much, Dr. Max. Next, we have Dr. Juan Blanco Morillo from the University Hospital Virgen de la Arizaca. I tried my best here. And he'll be presenting on Hemosep, a new cell saver technology to recover functional platelets and preserve coagulation.
Hello, thank you very much for the opportunity of being here, sharing our work. Our disclosures are these. Mainly that this research had no funding, but the donation of the equipment to do the research. As many of you know, currently one of the biggest problems that we have during cardiac surgery is bleeding and anemia and transfusion that increase mortality and interfere the recovery of the patients. It has been a few decades studying that, and this led to several recommendations of guidelines to move forward and implement measures to reduce this exposure to anemia and transfusion and bleeding. One of these is the adoption of cell-saving technology, but current guidelines highlight some benefits, but also some limitations, like the type of technology that when processing larger volumes of blood, we eliminate blood components like platelets and fibrinogen, leading to a potential coagulopathy. As we know, platelets play a relevant role in coagulation, not only in the cellular phase, and this traditional cell salvage technology that's based in centrifugation and washing eliminates the vast majority and also harms these platelets. So we found that something could be done. And in a certain point, this new device came to us, promising to be more gentle with platelets due to a process based in absorption. And there are some small RCTs talking about the possibility of obtaining a preserved coagulation, but there is none directly focused in assessing the platelet function. So we decided to run a research based in viscoelastic tests and flow cytometry. Now we're talking about viscoelastic tests. Flow cytometry will be a matter of another communication in the future. And we tried in the beginning to do a prospective randomized trial, but the lack of collaboration of some surgeons forced us to consider it not randomized. So we compared 23 patients versus 19, which during the surgical process were exposed to salt salivate, and well, some of them, all the blood was, all the bleeding during the surgery was recovered with an absorption device, and the other one was, the other group was with a centrifugation device, and also the remaining volume after the CPB was directed to the cell saver. Patients were within the age between 18 and 80 years old, proposed for elective aortic valvular surgery, and we avoided the inclusion of patients with preparative treatment of antiaggregants, septic patients, emergent surgery, reduce, coagulopathies, and other pathologies than the specified. What we did was to extract a sample post-protamine from the central access central catheter of the patient to see how was the coagulation after protamine, and also we analyzed how was coagulation and platelet function in the sample obtained from the cell saver. To assess the platelet functionality, we used the TEC6 device with a platelet mapping cartridge, exposing this blood sample to ADP and arachidonic acid, and we mainly measured the time to start the clotting, the angle defining the speed of the clotting process, and the maximum amplitude up to 20 minutes. What we saw initially was that when comparing both samples, samples obtained from a centrifugation device had a higher level of hemoglobin and a lower level of platelets, as expected. And we also found that samples obtained from the conventional cell saver were not able to form a clot, and the parameters observed in the second sample of the hemoabsorption device were very similar to the sample 1 obtained from the patient post-protamine. So we found that the time to form the clot was similar and very compatible to physiology. Also the angle, but in the non-treated sample and in the treated sample with the Hemosep, we also found that there was decreased stability of the clot that was similar between both samples. And when we tried to assess the effect of transfusing this to the patient, we found no difference in postoperative transfusion and bleeding. But also we have to assume that, considering that the volume transfused was the average volume transfused was 200 milliliters, and the average patient blood volume was 4 liters, was not surprising that we won't find significant differences. So as far as we were able to observe, Hemosep seems to preserve platelets and platelet function, obtaining a platelet count similar to physiologic range, and platelet function was similar to non-treated platelets with a cell saver after CPB. We also should highlight that the management of this device is not exactly the same, because the capacity of an hemoabsorption device to eliminate the plasmatic water and the crystalloid solution is lower. So we focused a lot on the right use of suckers during the surgery to avoid aspiration of saline irrigation. And also the process to recover these platelets takes around 20 minutes. Platelets, not the final product, including the platelets, takes around 20 minutes. So we consider that this could be a complementary device, not a substitute for current technology. Augmenting the weight of the processed blood or the relative processed blood according to the total blood volume of the patient seems us to expect a higher benefit. So it may play an important role in pediatric and small adults. And we also found that bioscholastic testing are a very useful measure to determine the impact of some perfusion approach, like the use of cell saver. But we require more evidence to determine the real benefit for these patients. As a take-home message, patient blood management should be considered as crucial in perfusion units to improve the outcomes. Thus, if we have not, we should include in our arsenal all these different techniques to reduce the exposure of patients to allogenic blood and improve the outcomes. Thank you very much for your commitment with perfusion science, and I want to thank also to my team for the opportunity of covering me being here. Thank you so much.
This abstract's open for discussion, both for those here in person as well as those on. I just want to maybe ask one question. Did you do a power calculation ahead of time to figure out how many patients you would need?
Yeah, this was not, we have not previous sample to compare. This is an exploratory study. So we proved after the trial, and we found that the amount of patients was close to be sufficient. Okay. So we should include like 3 patients plus per arm. But in the future, normally we should include smaller patients. Mainly, I think that to find a clinical advantage is crucial to have smaller patients. But according to the high differences between platelet functionality that was known in the control group, normally we are happy with these results. It's very evident.
Thank you.
I have a quick question. So do you think that there would have been significant differences in platelet function had you utilized a different device like PlateletWorks, where it's a direct measurement of platelet count and function post-surgery, versus using the TEG, which would be an indirect extrapolation of platelet count and function?
Yes, there is a difference because we did double testing. Here, I am not sharing the part of the cytometry, and it's a different assessment. And there are differences, but are consistent. So there's a deviation, like every time you use, for example, a blood gas analyzer, there is a difference. If you, with the same sample, you analyze in a Gem Premier, for example, and radiometer, there's a difference. So it was similar when you do the TEC6, or if you use a ROTAM, or if you use any other kind of device, you can compare tests with one device or with one system and the other.
Any other comments, questions from the audience? Do you have one? Or you did put it online? Luke asked a question. You just said that you did. What specifically does it eliminate that we don't want to get back to the patient?
Sorry?
The question was, what specifically does the system eliminate that we would rather not give back to the patient?
Okay. It mainly eliminates plasmatic water. It's based in it's a bag. The device is a bag and has a membrane. So everything that's below the pore goes to the GL phase and is eliminated. We also tested the interleukins, and it doesn't eliminate efficiently interleukins. So the micromolecules mainly are not so eliminated, and this is something also to take in consideration.
Thank you.
It's a concentrator.
Yeah. And given we just have a couple more minutes, there was a question, how many hospitals in the United States, if you're aware of, use the Hemosep?
I am pretty sure that none, because it has no FDA clearance yet.
Gotcha.
It has a CE mark, it's a British device, and went to the market during pandemics. So,
do you know in Europe?
In Europe, in Spain, we are trying this. We only received these samples to do the study, because in the beginning I found interesting, and I said, okay, I may use that, but I need to prove if it works.
Yeah.
And I think there are 2 centers using that in pediatrics, but they are not collecting data. And there are some studies from UK, because this is included in the NHS system. But I don't know exactly how many centers. This is an upcoming technology, so there is a lot of room for research in this regard.
Thank you. Appreciate it.
Okay, thank you very much.
Thank you so much, Dr. Morillo. Lastly, we have John Zavaro, a student from Lawrence Technological University, and he'll be assessing the system accuracy limits of the CDI System 550.
Good morning, and thank you for the opportunity to present today. As a student, we have to conduct a research project, and as someone who's never conducted research before, I wanted to go about sharing my experiences doing so and how I arrived at this topic. I have no financial disclosures. Institutionally, I'm a student at Lawrence Tech and will be for 42 more days. Just as a show of hands, who's used the CDI or currently uses it in a clinical setting? So a large majority of you. So you're well aware of the device itself. It's developed to enable continuous inline monitoring for blood parameters during CPB, and it has 8 measured parameters, and from it can calculate 4 others. And it has disposables, including the shunt sensor and the HS cuvette, that are installed at points in the circuit that allow for adequate exposure to blood. And I arrived at this because I was thinking of topics, and I looked at the pump and I saw the CDI. It's something that I've used at all of my rotation sites. And I was curious to see what could be done with it, because I feel like it's probably been examined so much before. So I did a deep dive into the literature and what currently existed. And one of the questions I had actually was, what was the difference between the 550 and the 500? So I looked up the 510K pre-market notification and found that the 550 was deemed substantially equivalent to the 500. The 550 came out in 2018, the 500 in 98, I believe. So the differences are, there are a few. They added a new calculated blood monitoring parameter, DO2, and they modified the alarm scheme. They expanded the hematocrit and hemoglobin operating ranges. They improved the temperature correction algorithm, and they improved the performance prior to in vivo calibration as measured by the HSAT module. Interestingly, since this was deemed substantially equivalent, it did not require any animal or clinical validation studies. Diving into the literature, I found these two excellent articles by Ottens and colleagues who aim to investigate the role of inline monitoring, and Trowbridge, Stemmers, and others investigated. They both examined intermittent blood gas sampling versus continuous with the CDI, and they both arrived at the conclusion that there is some benefit to using it during bypass, so much so that AMSEC under guideline 7.4 of the standards and guidelines for perfusion practice suggests that continuous inline monitoring should be used during cardiopulmonary bypass procedures. So the utility itself has been examined. How about the accuracy? Well, there have been a number of studies examining that too. So Rager and colleagues compared it with other devices as well, the Quantum and Balation and others also examined the accuracy with or without gas calibration. But they both arrived at a very similar conclusion, that it provides somewhat accurate data adhering to the manufacturer's recommendations. And Terumo itself said that this is a blood parameter monitor. It's not a substitute for an analyzer, and it requires periodic comparison to a laboratory reference sample. So I know what's been done before. I don't know which direction to take it in, so I started reading the operator's manual, and in Appendix B, they list system accuracy limits, which can also be found in the technical compendium. And they state that the CDI has been subjected to rigorous bench tests to simulate the clinical use of the device and assess its accuracy and precision over the system operating ranges. So for example, on the right, the pH, this means that on average, the CDI read 0.007 pH units above the analyzer, or for the hemoglobin, the CDI on average read 0.17 grams per deciliter less than the analyzer. So now I had concrete numbers, and to my knowledge, there was no study that compared these bench tests to simulated bench tests to an actual clinical setting. So I thought perhaps I could reproduce this in a clinical setting and see how the mean differences compare as well. So naturally, I had a couple questions. Rigorous bench tests, what did that entail? Simulated clinical use, test circuit, conventional analyzers, what type of blood, what type of circuit, where was it drawn in the circuit? Attempts to ascertain this information were unsuccessful, but I think that was a good thing, because if these are the published accuracy values, that is the expectation of the operator ultimately. So how would the bench-derived values compare to clinically derived values? So a null hypothesis in this case would be there's no statistical differences. This, again, was my first time conducting research, so a lot of it was learning statistical analysis and all of these different things. I wish I had Mel and Shauna's PowerPoint from earlier before I started on how to go about doing so. So I was basically going to recreate this in an actual clinical setting, but I really wanted to make sure I did this as accurately as possible. So I used it in accordance with its instructions for use. And all the values obtained prior to the initial in vivo calibration were excluded. Sometimes my first sample was before cardioplegia administration, sometimes it was after, and all of the subsequent samples were suitable for analysis. That first sample was omitted. I did a full 2-point tonometer gas calibration and a complete calibration of the potassium sensor. So if there was an emergent case and I wasn't able to do the full gas calibration, I excluded it from analysis. I avoided shunt sensor exposure to prime solutions and or blood with a pH of less than 7 or greater than 7.8. And I was mindful of the administration of intravascular dyes such as methylene blue. The sensors work on optical reflectance and fluorescence, and that would compromise the accuracy of that. We utilize a 1/2-inch venous line, so I used a 1/2-inch cuvette, and we used a shunt sensor on the arterial side. And I made sure that the flows were at least 1 liter a minute on the cuvette and 35 mLs a minute on the shunt sensor. So I was conducting this at my first rotation site, Tufts Medical Center. So the population was adults undergoing cardiac surgery. They were prospectively identified and non-randomized between a period of July 3rd to September 14th of last year. The CDI does not have any absolute contraindications for use, so I wanted to use it on as many different patients and surgery types as possible. The design was cross-sectional, observational, so no need for follow-up, completely de-identified, and there was no selection bias towards case type. I was the only person collecting the data, so there was no variation between the practices of the operators. It was only me. I had a couple different ways of collecting data, but ultimately I landed on this method. So as we know, we press store, we draw our samples, making sure that there have been no recent changes to FiO2, sweep, cardioplegia administration, temperature, and I would then immediately draw arterial followed by venous. We don't have a bedside blood gas analyzer, so they were sent to the anesthesia workroom, and you press store. We use AlphaStat strategy for our adult patients. We press recall. And what I would do is I would input all of the updated values on the lower. So the top row in the recalibration screen is the stored values. That would be the CDI. And the bottom row would be the ABL90 or the blood gas analyzer that we used. So that would be a quick way. So data collection, I found just taking a picture less than 5 seconds, and it was the least distracting from the patients. You're able to focus on the task at hand. And as I said, we used a half-inch venous cuvette with the optical window facing down to minimize interference from air coming down the venous line. And the arterial shunt sensor was inserted proximal to the sampling manifold using an extension line. And as I said before, the values prior to the that first in vivo calibration were omitted from analysis. So I initially started doing only one sample per case, but I found that I needed a large enough sample size, so I started increasing. So I used 43 pairs from 27 patients, 27 cases, leading to a total of 602 data points. And initially it was just one sample per patient, but I started increasing that towards the end. So there's both between subject and within subject variations. This was my first rotation, so a lot of the first cases were cabbages, but over time I started to get to do more complex ones. So there was, a transplant in there, an ACE ending with circ arrest, and a really complex one at the end. That was a lot of fun. So this is a lot, but this is just my raw data. And so if you can see here that the first row is a CDI, and then the analyzer, and then the difference. And I repeated that for all the parameters, and I took an average at the bottom. So that would be the mean difference. And from there, I could compare it to the published accuracy limits in the manual. So for instance, the first one, 0.007, the CDI read 0.07 on higher. For mine, can't quite see it, but it wasn't that much. And I compared, so bench was the published accuracy limits from the simulated use. The clinical was my result. And I just did a side-by-side, and I obtained some p-values, and I was learning which sample test to use. I arrived at a one-sample z-test to compare the two, given that they provided the standard deviation for their tests as well. So the only two values which had only two parameters which had a p-value of less than 0.05, which I selected as my significance threshold, were the PaO2 and potassium. According to the manual, they claimed that the PaO2 was minus like 0.5 less than the analyzer, whereas I got 3.95 greater than the analyzer on average. So they're statistically significant. However, is it clinically significant? Am I happy knowing that my CDI is only reading 5 millimeters of mercury higher on my PaO2 sensor? I'm very much comfortable with that. So it depends on the user itself, and there's certainly a lot of limitations. This was a single center study, not a large sample size, only 43. Lack of information about what they did. I traced back to 97 the 510K disclosures prior to Terumo acquiring CDI, and they said they used a blood loop. So that's kind of one step in the process, but I could recreate this or continue doing so, perhaps integrating more statistical analysis and, just expanding upon this beginning. I had never conducted research before, so this was a great way to start with some data that I could easily collect. So thank you to all of these people for paving the way and making this possible for myself. I wouldn't be here without you. And thank you for the support from LTU and Tufts Medical Center.
Thank you, great job. We have maybe comment, a short question and a short response.
Hi, it's me again. Thank you for this nice study. I gotta say, about 10 years ago, we did exactly the same thing. Like, I can, when I see you do it, it's exactly like we did, and we came also to the same conclusion, that it was statistically significant, but not clinically, because it was, as you say, so either we did both the bad job or we did both the good job. So, but we never published it, and because it was also a student, and we did multi-center, 2 or 3 centers, and we had a lot more data points, but we came to the same conclusion. So good job.
Awesome.
Thank you.
That's great.
Thank you. Thanks.
So that's the conclusion of this session. There is lunch, there are lunch boxes, and so please feel free to go grab some, come back, and we get to have a potty.